Assalamu alaikum wa rahmatullahi wa barakatuh. During the following minutes, I will discuss a very important topic. It is important to all surgeons that are looking forward to restarting elective surgeries post-lockdown. This issue should be handled in a well-organized guidelines. Otherwise, disastrous outcome will happen. On the top of these measures are the preoperative precautions that will be discussed during this lecture, which is titled Preoperative Guidelines, Mitigation of Ban on Non-Emergency Surgeries. We used to deal with different aspects of any health problem through well-organized guidelines that will optimize the quality of care, improve the outcome, and aspire to be cost-effective. For the current health problem, the situation is different. All the available information are recommendations and did not reach the level of guidelines. Most of the countries stopped elective surgeries for many reasons, leaving the decision for later consideration. Hence, I tried my best to assemble these guidelines, and of course, they need future reconsideration. If we would like to mitigate the ban, we should know the reasons behind these guidelines. These guidelines are intended to aid the development of consensus regarding approaches. When this plan is carried out in all surgical units, can also be a part of pandemic suppression campaign. The only way forward to continue surgical services is to initiate standard routine testing. Surgeons need to understand everything about the available tests. Providing surgical services without being strict in applying these tests could have disastrous consequences. There are certain facts that are to be considered in the creation of these guidelines, and will include the instructions of health authority. This pandemic keeps changing. All countries are looking to the inflection point in the exposure graph. The R0 for COVID-19, which is equal to the basic reproductive ratio and represent the number of people infected by one confirmed patient, and this will reflect how contagious a disease. It is usually measured in relation to 1. If it is more than 1, it means there is an increase in the spread. If it is less than 1, it means there is decrease in the spread. For COVID-19, range from 2 to 3.5. Other facts, the availability of antibody tests and PCR tests on wide base. PCR is a highly specific test. Once it is positive, there is no doubt that this is a case of COVID-19. Also, we should not forget the cost. These tests are expensive. All pandemics poses many challenges to health workers. About 3.8% of infected patients in China were health workers. This will add burden on the health workers. For example, prolongation of shift duties and involving of non-specialized staff in respiratory care. Surgeons play an important role in this pandemic, as suspected or confirmed cases may require surgical interventions. Keeping in mind some of the procedures are called AGB, or aerosol generating procedures. Also, there is no previous experience in managing such pandemics. Asymptomatic patients are the main source of spread of infection, representing 30 to 50%. Transmission can occur before the onset of symptoms. Also, very important fact are the false negative patients, representing 30% with PCR test. This have both political and medical consequences. There are causes for false negative tests, and the most common one is the improper sampling. Sampling usually done through swabs of the nasal and the throat mucosa. The virus is deeply seated in the mucosa of the back of the nose and the back of the throat. And of course, there are other causes. The last fact to be considered is the type of surgery. Surgeries are classified into 4 groups according to the urgency to perform. First group, emergency surgeries, in which you have to do the surgery within 1 hour. Second group, urgent surgeries, in which you do the surgery within 24 hours. The third group, urgent elective surgeries, which can be done within 2 weeks. And finally, the elective surgeries. Elective surgery is not optional one, rather implies that a procedure is not immediately indicated. It is subclassified into 2 types, either essential, in which surgery can be done within 1 to 3 months, and discretionary, when the surgery can be delayed for more than 3 months. Considering these objectives and facts, patients who are scheduled for surgery should always be assumed to be potential carriers of the virus throughout their hospital stay, even if they pass the pre-assessment. The guidelines must include the following. Number 1, national health situation. Number 2, consider the possibility of COVID-19 infection in every patient. Number 3, type of surgery. Number 4, clinical assessment. Number 5, perform PCR test and antibody test 24 hours before the surgery for all patients. Number 6, you may consider CT scan of the chest when there is high clinical suspicion and negative PCR test. And finally, isolate the patients in their rooms. No visitors are allowed. Maybe 1 visitor for 15 minutes per day with a distance of 1 to 2 meters away, and of course wearing appropriate protection such as surgical mask and gown. Interpretation of the results of the screening test. There are 3 possibilities. First possibility, positive PCR. This means acute infection. The patient should be isolated and surgery is postponed. Second possibility, negative PCR with positive antibody test, not require further testing during their hospital stay. The third possibility, negative PCR and negative antibody test. The patient should be tested with PCR every week during the hospital stay and always undergo an exit test PCR on discharge. And maybe we can add a 4th possibility regarding the false negative result. Thank you very much.